في another talk ما شاء الله عليك.
Okay, so now I will invite Dr. Amal, consultant cardiologist, and Dr. Amira, consultant cardiologist, for chairing the next session, which will have actually 2 presentations, and my presentation will be only discussion. I don't have any slides. So I always believe that discussion, it makes people wake up and get, not get bored. So the floor is for the chairmen.
Thank you. Good evening, everyone. Thank you for showing up all. And let us start with our eminent speaker, Dr. Hani Sabur, consultant cardiology in Mid Clinic Airport Road, and consultant for heart failure, for pulmonary hypertension, and he's the eminent one in this field and supporting all, I think, all Abu Dhabi doctors and maybe all Emirates. Dr. Hani?
Yes, thank you, Dr. Amira. I'm just gonna come back to, again, another very important topic, and I'm gonna try and address it from a slightly different angle. So we want to look at the SGLT2 inhibitors as a clinical class, looking at the clinical trials, and specifically now with this new syndrome, this cardio-kidney metabolic syndrome, as an overall look. So the cardio-kidney metabolic syndrome is now a new syndrome. It has now been officially adopted by the American Heart Association, and it's very important for us all to know it, because all of you are seeing patients with all of this syndrome. So this syndrome starts at this stage. So this is simply adipose tissue, obesity, abdominal obesity, and impaired glucose tolerance. The next step is something that all of us will see, and the earlier stages, if not treated, will now fall into stage 3 and stage 4. So this is a syndrome with multiple phases. Now, the patients with metabolic syndrome have this disease, but it hasn't been formally recognized as a disorder. So you have metabolic syndrome, you have the visceral obesity, you have CKD, diabetes, and hypertension. So you have non-metabolic etiologies of hypertension. So this excludes sleep apnea. I'm talking about renal artery stenosis. And you have non-metabolic etiologies of CKD. But by far, these are the commonest, and these are the easiest to treat. So in primary care, these 2 boxes are literally the most important. Now, when patients come to our clinics in cardiology, they've already achieved stage 4. So heart failure, peripheral artery disease, atrial fibrillation and stroke, also congestive heart failure and coronary heart disease. There's an additional stage that you can achieve through screening if you look for coronary calcium or diastolic dysfunction. These are high-risk equivalents, and the kidney component of this is just as important. So very high-risk CKD are patients with albuminuria or CKD 4 and 5, or cardiovascular risk urine calculator. So you see this overlaps a lot of the patients that you see every day in clinic. So one of the important points to consider now is, why did we discover this? How did we know that there is this syndrome, right? So we didn't really know this until earlier, and we didn't know how the interaction between the kidney and the heart was so strong and so positive. So in patients with CKD, look at the patients with CKD, right? The majority of these patients have coronary artery disease, heart failure, and have had either ischemic events or not. Without CKD, this number shrinks tremendously. So the heart failure drops to 18%, acute MI drops to 6%, and CVA and TIA drops to 20%. So without CKD, there is a lot less cardiovascular disease. Cardiac renal disease is directly interacting. And this has been known for decades in the diabetes literature. This is the IDF Atlas, but I don't think any of us started to see this until the SGLT2 inhibitors started to show up. So type 2 diabetes results in a 5-fold increased risk of heart failure. Type 2 diabetes, 40% will have CKD. CKD, 10 to 20 times higher risk of cardiovascular disease and death among CKD patients, and 40% of early stage CKD, CKD 3 only, right, are at very high risk of cardiovascular events. And of course, if you have heart failure, the CKD worsens, so it's a vicious cycle. So this is the cardio-renal interaction that was discovered by the diabetologists. So now I'm going to come back to one of the solutions, and it's the SGLT2 inhibitor. So Braunwald made this really brilliant paper, and he said it many times. The SGLT2 inhibitors are the statins of the 21st century. And he mentioned several drugs that have resulted in the Nobel Prize: aspirin, penicillin, and statins. The SGLT2 inhibitors, however, are now effective in diabetes, heart failure, kidney failure, and represent, he said, the or one of the major pharmacological advances in cardiovascular medicine in the 21st century. And this is the man who has generated literally 90% of all of the evidence in cardiology that you've seen. So empagliflozin from the EMPERIC outcome study is where the story started, right? This is where we discovered that diabetes drugs could have more than just glycemic control. Then we've gone to EMPEROR preserved and EMPEROR reduced, EMPEROR kidney. Now we have IMPERIAL, and this is also a real-world study, and the EMPRISE real-world studies that are non-randomized. So how do these therapies work? The therapies work using a very simple mechanism that we know. We know that they increase tubuloglomerular feedback. By restoring the TGF, there is SGLT2 inhibition in the proximal tubule and therefore reduces renal hyperfiltration, which is the earliest stage of diabetic nephropathy. Fantastic. So it has an effect on the kidney. How does it affect the heart? In fact, one of the things it does in the heart is something we didn't know until the SGLT2 inhibitor, the EMPERIC study. Because it affects the metabolism within the heart itself, it actually has this impact of the AMP kinase and the SIRT1 reducing exudation and autophagic flux. This is a very complex mechanism that's described in this long paper, but it has a cellular effect on the myocardium. The additional benefits that we've seen is prevention of heart failure. So for the first time in the SGLT2, the EMPERIC study, we saw a reduction by 36% of patients who never had heart failure. We didn't even know they had heart failure. And they reduces preload and wall stress, improves cardiorenal function, the sodium-hydrogen exchange sprung, and reducing interstitial edema and natriuresis. So this is the cardiorenal axis. And you see here with the SGLT2 inhibitor, you have natriuresis, which improves the intraglomerular pressure, but also reduction of fibrosis, inflammation, and glomerular damage, plus cardiovascular protection. Renal and cardiovascular protection go hand in hand. Now, as cardiologists, we want to understand how does it work on the heart, because we've seen it now in heart failure with reduced ejection fraction, and more importantly, in the earlier stages of preserved ejection fraction. So just to simplify, what is diabetic cardiomyopathy? It's also called metabolic inflammatory cardiomyopathy. It's a heart failure that is characterized by the presence of abnormal heart performance without coronary artery disease, without significant valvular heart disease. So a normal heart looks like this. It's elastic, and it's not very stiff. A diabetic cardiomyopathy, there is LVH, there is fibrosis, the left atrium is dilated, there is reduced E prime, i.e. it is less elastic, it's less able to stretch and dilate. And this is something that was described back in the 1970s. So in 1972, they did a series of autopsies in patients with diabetes who died of heart failure, who did not have coronary artery disease, no coronary artery disease. And what did they see? Intense perivascular fibrosis, intense intramuscular fibrosis, and ventricular hypertrophy, causing heart failure. This is HFpEF, but it was not known at that time in 1972. So the SGLT2s now protect the heart how? By preventing diabetes-associated vascular remodeling, which is hypertrophy, inflammation, increased extracellular volume, impaired cardiac metabolism, and cellular apoptosis. Necrosis of the myocardium seems to be decreased with the SGLT2 inhibitors. In addition, the impact on the sympathetic nervous system is seen here. So this is a very important mechanism because you also have hypertension and heart failure in the diabetic patient, and there's activation of the sympathetic nervous system. SGLT2 inhibitors reduce the sympathetic nervous system, therefore reduce RAS activation and have an impact on the kidney. So there's a direct impact now on many different features that we never know. This is not just a glucosauric drug. Now, how does it work as a diuretic, if you would? That's a very oversimplified wording, but remember in patients with congestive heart failure, there is interstitial myocardial edema. There's expanded ECV if you look at cardiac MRI. So the loop diuretics, what do? They decrease the intravascular volume, they decrease the interstitial volume, and cause natriuresis. SGLT2 inhibitors do not significantly reduce intravascular volume. That's why you can use them in heart failure patients. But they do cause natriuresis and reduce interstitial volume, making the myocardium less stiff and less edematous. Also, the mechanism in the cellular cytoplasm and also in the mitochondria, because it has an effect, it's a sodium transporter, so it has an effect on the sodium-calcium cotransporter and the ATPase and the hydrogen exchange too. So it makes it more efficient in terms of energy. Now, this is a very nice mechanistic paper that summarized it all together. So this is the direct effect of SGLT2 inhibitors, but it also does something else. Increases hematocrit. And by doing so, it also, because it's a diuretic, in some ways it decreases the plasma volume with increased hematocrit. So what happens? The plasma osmolality remains neutral. Blood pressure is reduced, so you're now reducing preload and afterload, and also it prevents activation of sympathetic nervous system and renin-angiotensin. It's almost like ARNI or an ACE inhibitor. Plus reduction of cardiac fibrosis, and the stress on the myocardium is significantly reduced, and this is seen in mechanistic studies, leading to cardiovascular death and heart failure hospitalization. Something remarkable that we never expected. Now, this is another study that came from Subodh Burma's group. This is CardioLink 6 using empagliflozin in patients with left ventricular hypertrophy and patients who had diabetes and LA and coronary artery disease. Using cardiac MRI, not visual assessment, there was a significant reduction in LV mass index from baseline within 6 months using empagliflozin with cardiac MRI. So this is clearly making a structural change in the heart. SGLT2 inhibitors, and I've listed these studies here, all of them reduce LV mass index and improve E prime. And if you look very carefully at the global longitudinal strain in patients with HFpEF, HFmREF, and reduced ejection fraction, there's a significant improvement into the E prime ratio and also in global longitudinal strain over just 6 months of adding SGLT2 inhibitors. So we got all of this data from the cardiovascular outcome studies. What were these studies designed to do? Actually, the FDA just wanted to make sure new drugs with diabetes don't kill people, like Avandia, increase the risk of death and mortality. So that was the safety. What happened was they had 3 points of CV death, non-fatal MI, and non-fatal stroke. The landmark study that came up first was EMPERIG, and that was quite remarkable. It was not, and some of the data in that has not been reproduced since then. So we talked about the mechanism in diabetic kidney disease, and we talked about the mechanism in heart failure. They're very, they're very similar, except that the kidney is now helping the heart and the heart is now helping the kidney, and that's really a key component. Now, the SGLT2 inhibitors reduce the A1C only by 0.5 to 1%. That's not the main reason. There are much more potent glycemic drugs. Lowers the body weight, lower the blood pressure, increase hematocrit, reduce uric acid, but at the heart level, LV mass regression and global strain, reduces renal hyperfiltration and albuminuria, but also reduce BNP and troponin. It's not revascularization, it's decreasing cellular apoptosis and has a slight increase in LDL. The inflammation and atherosclerosis is unique because it reduces epicardial adipose fat, improves endothelial function, also reduces fatty liver, and of course the metabolic component of HbA1c as well. So the historical development of the diabetes studies did start with EMPERIG, and this whole avalanche of information has come all of that. So we've evolved from these studies that looked at MACE endpoints into primary prevention endpoints, secondary prevention endpoints, renal endpoints, heart failure endpoints in patients who are diabetic and non-diabetic. So this is like a big summary of the major studies. And all of them have been positive, right? So the non-diabetic type 2 diabetes with CKD and diabetes, these are CKD studies. So Credence, DAPA-CKD, EMPA-Kidney, and SCORED. Heart failure studies, DAPA and EMPA-Reduced, EMPA-Preserved, and DELIVER. Type 2 diabetes and CV risk, DECLARE, and the primary outcome Canvas. And of course, EMPERIG, Canvas, DECLARE, and VERTIS. So it's an enormous amount of patients that benefit from this stuff. So the extended RCTs have now been completed, showing a benefit in all heart failure and chronic kidney disease with and without diabetes. So this is all the studies that have been reported and published. So there is one class effect, and that is what? Reduction of heart failure hospitalization. That is a class effect. All of them do it. There's no real difference between them. And when you look at the heart failure, even in real-world studies, this is the EMPRISE real-world study with empagliflozin versus DPP4, or the CVD Real, which was DAPA versus other glucose-lowering drugs. It still holds true. Now, what about MACE? This is very important now. MACE is different, and we don't exactly know why. Only the EMPERIG outcome study showed a significant reduction in major adverse cardiac events. Credence was a CKD study, not an ASCVD study. And we didn't get the same, not significant with Canvas and not significant with dapagliflozin. If you look at the hazard ratio, the risk of these patients, the EMPERIG outcome study had the highest risk of all of the studies that included ASCVD. Credence was a renal study, but only EMPERIG showed a significant difference in MACE, even comparing the very high placebo event rate, which is almost 15% here, you still have a tremendous reduction of cardiovascular outcome in the highest risk patients, particularly with ASCVD, not known to have heart failure. Now, the multiple complications in diabetes are reduced as sort of a meta-analysis. heart failure, hospitalization, and CV death. The renal endpoint is tremendously reduced, and all-cause mortality is reduced as well. But if you look at the specific, as Dr. Sharif mentioned, you have to look at the study design and replicate the patient you apply it to. So when you look at the CV outcomes, CV death is only seen in EMPERIC outcome study with empagliflozin. MACE is only seen in EMPERIC outcome study with empagliflozin, and heart failure is seen in all of them. So I think this is an important differentiation when you see a patient with atherosclerotic cardiovascular disease and diabetes, what SGLT2 inhibitor to use, you have to use the empagliflozin. CV death, again, only EMPERIC showed cardiovascular death significant. All of the others were non-significant compared to cardiovascular death. Now, triple point MACE, again, EMPERIC showed a significant reduction in ASCVD events. All of the others were not significant. However, if you look at patients with prior MI, and that was the majority of patients, 75% of patients in the EMPERIC study had a prior MI. That what seems to drive the event rates down. No ASCVD event, triple point MACE is not going to change. Now, heart failure, regardless of ASCVD, if you had a heart attack or didn't, it didn't matter. All of these drugs reduce heart failure from a primary outcome. So the largest was 35% with EMPERIC, CANVAS, DECLARE 26%, and VERTIS 30%. Renal outcomes, as I mentioned, what's good for the heart is good for the kidney, and what's good for the kidney is even better for the heart. This was the starting point. EMPERIC, CANVAS, DECLARE, all of them reduce the progression to renal failure, death, or renal disease. So what about the side effects and the potential contraindications? Okay, so this signal of vascular amputation is not there. The EMPERIC outcome study did not show any increase of lower limb amputation. Initially, in the canagliflozin data, there was a black box warning. It's now been removed. Both CANVAS, CREDENCE, and DECLARE, there was no increase in lower limb extremity amputation. So this is not a reason not to give these therapies. All of the adverse events, such as fracture and diabetic ketoacidosis, across the board from all the studies are extremely rare and should not be used to deprive patients of these life-saving drugs. So now we have a summary here. The SGLT2 inhibitor trials have gone from heart failure prevention in diabetes, heart failure treatment in both diabetic and non-diabetic patients. So these are all the studies, and literally not a single one of these studies is negative. They're all plus, plus, plus with very high p-values. And of course, with heart failure, it was evolved even more, so that now we are using patients without even severe heart failure, preserved ejection fraction, which was something that had no treatment whatsoever, and now is strongly positive with both DELIVER and EMPEROR preserved. So the impact across all of the cardiovascular and renal outcomes is completely independent of glycemic controls, and all of the societies are recommending this for reduction of MI, stroke, and CV death risk in diabetics with ASCVD, reducing incident hospitalization with diabetics with risk factors or CKD, and reduce renal progression and high risk for CKD. So treatment of heart failure regardless of ejection fraction, treatment of CKD over a wide range of GFR and albumin-creatinine ratio, which means you have to test for it, and all diabetic patients regardless of HbA1c. That is 100%. How many patients in the UAE receive 100% SGLT2 inhibitors? 30%. So the observations and conclusions that I want people to take home from is that the SGLT2 inhibitors, led by empagliflozin with the EMPERIC outcome study, prevented heart failure even when we didn't know the patients had heart failure. Preventing heart failure when there's only a risk of heart failure. Preventing progression of heart failure from diastolic to systolic dysfunction, and even improving heart failure survival, which is heart failure treatment. Preventing heart failure even with really bad kidney function, regardless of renal function, i.e. And preventing renal and heart failure in patients with advanced CKD, even when the glucosuria mechanism isn't contributing. It's direct cellular mechanisms that we talk about. Also, effect on heart failure hospitalization and heart failure death with normal or even reduced ejection fraction. So this is regardless of the A1C and regardless of the ejection fraction. So this is literally the universal drug that Braunwald mentioned. So Braunwald's 4 rules for SGLT2 inhibitors are summarized here. They are not only glucosuric, but prevent development and progression of heart failure and prolong life in diabetes and reduced LV function. They also improve outcomes across the board in HFrEF, with or without diabetes. They also work in patients with chronic heart failure in any ejection fraction class, and also in end-stage kidney disease, slow the progression of end-stage kidney disease in patients with chronic kidney disease. So the benefit is seen in SGLT with kidney disease and diabetes, but in all other conditions. So I think the take-home message is this. This is a universal drug that every one of us has patients that would benefit from. And if you don't see your patients with diabetes on it, ask why and put them on it. If you don't see patients with CKD on it, ask why, put them on it. If you don't see heart failure patients on this therapy, preserved or reduced ejection fraction, please put them on these life-saving drugs. And we owe it all to the EMPERG outcome study that showed us the way and the path. Thank you.
Hari, great as always. So we have 5, or I'm not sure, maybe 6 SGLT2 available. And to be purist, as you said, we need to go with the design and population involved. So now we have more with this one, IMPA and DAPA. The question I have, one of the reason I use maybe one of them is when I have a combination easily available, so especially the one which protect the kidney. Yeah. For example, here we have Impalina, which is, both of them are good for diabetic and kidney.
With CKD,
so,
yes.
I don't know what your approach.
So again, I thank you for that. You have to take a holistic approach to the patient, right? So a diabetic patient with some degree of CKD, you have to select the therapy that is going to treat the diabetes and also have no impact on the kidney or the heart. So a combination of metformin and SGLT2 inhibitor, or a combination of linagliptin, which has been proven to be safe in the lowest ranges of GFR, is very reasonable with empagliflozin. Now there is data for the dapagliflozin also in CKD, so that's called the DAPA-CKD study. So the difference, though, is that if you have a patient, let's say the patient comes to my clinic who is a cardiac patient, just been discharged from the ICU with an acute myocardial infarction, has mild LV dysfunction, has newly diagnosed diabetes, right? The hospitalist has discharged the patient on insulin. My first reflex is to put them on an SGLT2 inhibitor, but given the fact that they have ASCVD, I know that the EMPERG outcome study is going to influence that decision, right? So that would be my first step. The other thing that's going to be very important, in addition to maximizing the lipid-lowering agent and making sure they're on the right ACE or ARB, and also making sure that the ejection fraction is correcting, is also to look at additional things, like the kidney. I have to look at the kidney. Now the doctors, the cardiologists have to look at the kidney. It's literally part of our armamentarium. If the patient has albuminuria, then I have to add finerenone, right? If the patient has uncontrolled diabetes and obesity, I would be adding a GLP-1 receptor agonist to reduce cardiovascular risk. So now you have at least 3 or 4 tools to treat the same patient, and I think you have to take each one with evidence. So that's really the approach. You really now have to think of an expanded toolbox beyond aspirin, beyond statins, beyond the antiplatelet therapies, and really look at what these other agents offer for your patient. And of course, if the phenotype fits, apply it to the clinical study.
Okay, any question? I thank you. Thank you, Dr. Hani, for your elegant presentation. It is my pleasure to introduce next speaker, our elegant speaker, Dr. Joseph Kurian, consultant cardiology, LLH. His topic, cardiovascular disease and diabetes.
Yeah, this is a slide. So good evening, ladies and gentlemen. It's a difficult task to follow Dr. Hani anyway, and I think he has described everything about diabetes in the 2-3 talks he had already given. We'll see how we can prevent cardiovascular disease, how to prevent mortality in cardiovascular disease, what we can do. And yeah. So the commonest reason for that mortality in cardiovascular diseases, in diabetes is cardiovascular disease. Nearly 80% of all people die due to cardiovascular disease, 75% from coronary artery disease, 25% from peripheral vascular disease or stroke. 75% of all hospitalization for diabetic complications are due to cardiovascular disease. By the time we diagnose diabetes, nearly 50% of them have vascular disease. Just we have to look for it. And as was seen in the PACMIA study, 99% of our diabetic patients were high risk or very high risk. So nearly all of our diabetic patients fall into the high risk or very high risk. And if you look at the causes for atherosclerosis, there are environmental and genetic factors. Diabetes is definitely an important predisposing factor. By the time we diagnose diabetes, 50% have cardiovascular disease. It's a global pandemic. Currently nearly 600 million, expected to go to 900 million by 2045, nearly 800 million. 537 million in 2021, and expected to go to, say, 783 million by 2045. 6.7 million deaths annually due to diabetes. Most of the death is due to vascular disease. And the high blood sugar we see in diabetic patients is just tip of the iceberg. These patients have a lot of factors which predispose them to accelerated atherosclerosis, which is the metabolic syndrome or insulin resistance syndrome. They have, say, in addition to high blood glucose, the hypertension, dyslipidemia, abdominal obesity, platelet dysfunction, hypercoagulability, microalbuminuria, vascular inflammation. Put together, we call it the metabolic syndrome. The components of metabolic syndrome are there for 5 to 10 years prior to the diagnosis of diabetes. Actually, the diabetes disease process has started around 5 to 10 years prior to we diagnose diabetes, that many of them may go into an accelerated atherosclerosis even before they develop diabetes. And this is just to show that the disease process has started nearly 10 to 15 years prior to we diagnose diabetes. And you can see that the heart failure is increased by almost 5 to 10-fold in diabetes compared to non-diabetes. And this is one of the large study where the landmark study actually by Hafner et al. That diabetes is a CAD risk equivalent. It's good to consider all our diabetic patients as CAD risk equivalent. I fully agree. Some of the newly diagnosed diabetic patients are not CAD risk equivalent. But if it is good to protect them. Unless we consider them as CAD equivalent, we will not give them the protective medicines, including the SGLT2 inhibitors, the statins, antiplatelets. This is one of the large study in follow-up for 40 years. They found that diabetes is as bad as an MI or stroke. The mortality is exactly same like a person with a history of MI or stroke. If you have all these three things together, the risk is almost 10-fold higher. And this is a 30-year follow-up of the Framingham study. The heart failure is 5 to 10-fold higher, 5-fold higher in males and 10-fold higher in females. This is, again, a large study which showed that the lowest incidence of cardiovascular disease is at a blood sugar of 85. It's not that below 100 we are totally protected. So it's a continuous variable. From 85 onwards, there's a steady increase in all vascular events. Maybe with the exception of hemorrhagic stroke, all other vascular events significantly increases. This was the 10-year mortality in diabetic patients from the 1970s to 1990s. See that the 70s and 80s, actually the mortality was the same. By 90s, it has come down by almost 50%. But even in the 90s, there is a significant difference between the diabetic and non-diabetic. Here we can see that the all-cause mortality, it has come down both in diabetes and non-diabetic, but the non-diabetic, it has come down markedly. While the diabetes is at plateau down after some time, while the vascular events have come down significantly both in diabetes and non-diabetic. But there is a significant gap which remains that we are not able to fill up. The diabetes even now remains, the mortality remains higher compared to non-diabetic. The left column, the high, that is mainly because they say the heart failure incidence is high. That's why the all-cause mortality is still remaining high, even though the other vascular death is coming down. This is just to show what are the factors which are extremely important in decreasing vascular events. The LDL reduction had the best impact, followed by the blood pressure reduction and the blood glucose. One of the best ways to prevent mortality in a diabetic patient is to prevent diabetes itself. So if you diagnose diabetes in the 20s and 30s, you lose almost up to 16 years of your life. While if you diagnose diabetes in the 60s, you just lose 6 years. So if you prevent the onset of diabetes, you save more years to their life. So the best way to prevent mortality in diabetic patients is to make sure that delay the onset of diabetes. And the best way to delay the onset of diabetes is weight reduction. And obesity is the main driving force for the pandemic of diabetes. And fortunately today we have effective medicines to reduce obesity. And the GLP-1 agonist, the SELECT study has found that with the anti-obesity dose of semaglutide, there was almost a 20% reduction in cardiovascular events. These are the intensive treatment with blood glucose lowering. All the microvascular events came down significantly. But that was not the case with the macrovascular event. Only the UKPDS trial found a significant reduction in macrovascular events. Even that took almost 20 years. So even the newly diagnosed diabetic patients almost took 20 years to have a significant reduction in macrovascular events. This was just to show that the macrovascular events, there was a modest reduction in the intensive treatment of blood glucose. But that was not the case in the ACCORD study. ACCORD study, the result went the other way around. The mortality was higher in the intensively treated patients. This was just the normal blood glucose, the upper quartile versus the lower 3 quartile. In a 25-year-old follow-up, the upper quartile of normal blood glucose had a significantly higher all-cause mortality compared to the lower 3 quartiles. So a lot of reasons for accelerated atherosclerosis in diabetic patients, including hyperglycemia, advanced glycation end products, dyslipidemia, hypertension, inflammation, hypercoagulability, platelet dysfunction, oxidative stress, and many more. So as many of these factors we have to control, and the two important ones are the hypertension and dyslipidemia. Controlling these two have been shown to have a significant reduction in cardiovascular events in many studies. Quite often what happens is that when we look at controlling the obesity, the weight reduction, maybe we are able to get to some extent to start with, but to sustain it is difficult. If you are able to get a significant reduction in, say, a 15% reduction in the body weight, we are able to decrease all-cause mortality, cardiovascular mortality, and nearly a good percentage of them go into diabetes remission. We are taking the patient away from diabetes. So preventing diabetes, we prolong their life. And the heart failure with preserved ejection fraction significantly improves by reducing obesity. And they had the STEP heart failure study, both in diabetes and non-diabetic tests found that controlling obesity with the GLP-1 agonist, the heart failure incidence had, at least the BNP and the quality had come down. It was not the hardcore endpoints like heart failure hospitalization or mortality. But the unfortunate thing is that to maintain weight reduction is not easy. It's a chronic disease. It should be considered as a disease, and it needs long-term treatment. In the obesity, there are a lot of factors which predispose to accelerated atherosclerosis, including the insulin resistance and obesity, dyslipidemia, hypertension. And obesity meets all the criteria for a disease, and it should be treated like a chronic disease. There are nearly 800 million people with obesity all around the world, and 200 million adolescents with obesity. Obesity, one risk factor where the medical community has failed miserably is controlling obesity. At least to some extent, we had been able to control the hypertension and dyslipidemia. While controlling obesity, we have failed miserably. In fact, it is going up. This was one of the studies in which it was, if we decrease the weight by 15%, 86% of the patients goes into diabetic remission. So if you are able to reduce 15 kilogram weight in the early part of diabetes, in the first 5 years of diabetes, most of the patients goes into diabetic remission. This was one of the diabetes prevention study. Even the cardiovascular mortality and all-cause mortality comes down significantly. But the unfortunate thing is to sustain that weight reduction is not easy. The initial dip followed by the increase. So I'll just discuss the ESC guideline, the current guidelines, and the new modifications to the previous guideline, which was published in 2019. Every diabetic patient, we should look for the presence of cardiovascular disease and target organ damage. And in patients without cardiovascular disease or target organ damage, calculate the 10-year risk. They have the score 2 diabetes risk stratification. And overweight patients, weight reduction should be advised, and GLP-1 agonists are the preferred one. And in blood glucose control, we have to be proactive. We need to make sure that we control the blood glucose early. The UK PDS trial, 1 millimole reduction, the 1% reduction in A1C had led to a significant reduction in cardiovascular events. Unfortunately, we have at least 4 or 5 group of drugs which have low risk of hypoglycemia, weight neutral, and has cardiovascular safety, proven cardiovascular safety. So use these drugs to get the A1C to the control, aggressively treat them. At least a verified study found that early combination treatment is definitely better than sequential combination. These are the various trials, and in every diabetic patients, look for the presence of cardiovascular disease, look for renal disease, and risk stratify them. If the patient has cardiovascular disease, they should be on a GLP-1 agonist or SGLT2 inhibitors. If the patient has renal disease, they should be on SGLT2 inhibitor and finerenone. And every cardiac patient, we should look for diabetes and prediabetes. There is a risk stratification, the score to patient with a 10-year risk of more than 20%. Very high risk, more than 10% is high risk, and 5 to 10% is moderate risk. Actually, there is nobody with low cardiovascular risk in diabetic patient. They are at least moderate risk. And the PAC-MIA study, 99% of the patients were high risk or very high risk. It is recommended to look for the presence of target organ damage, cardiovascular disease, and risk score assessment. All are class 1 indication, more than 20% very high risk, 10 to 20 high risk, and 5 to 10% moderate risk. Overweight correction, treat them with the anti-obesity dose of GLP-1. Recommended to follow Mediterranean diet or plant-based diet and increase physical activity, cessation of smoking, tight glycemic control. As an individualized, old age with limited life expectancy, you may relax it a little bit. Young patients definitely try to get below 7 or below 6.5. And always use drugs with a proven cardiovascular safety or cardiovascular protection like the GLP-1 agonist or SGLT2 inhibitors. Then additional glucose lowering is needed. Maybe pioglitazone has 2 trials which have shown cardiovascular protection, including the PROACTIVE and IRIS study. BP should be lowered to below 130/80, and we have heard a lot about the LDL reduction. LDL reduction is one risk factor modification. The lower is the best. Even if you go to 10 or 15 milligram of LDL, still the patient benefits. And if with high intensity statin, the goal is not reached, go for a combination with ezetimibe or PCSK9 inhibitor. This is the meta-analysis of various trials with the SGLT2 inhibitor. If you look at the 3-point MACE, even the CANVAS study had the same 3-point MACE reduction like EMBARAC. Both had 14% reduction. So 3-point MACE, the empagliflozin and canagliflozin had the same 3-point MACE reduction, while the DECLARE it was a little less, and the VERTICIV it was neutral. Patients without established cardiovascular disease, the lowermost, we can see that there was not too much of a benefit with the SGLT2 inhibitor. One clinical endpoint, it was significant. That was heart failure hospitalization. Second was renal endpoint. These two are class effect. While for 3-point MACE, it was only CANA and EMBA which had shown significant reduction. This is with the GLP-1 agonist, the various studies. Actually, the vascular event reduction was a little better with GLP-1 agonist compared to SGLT2. There was a 15% reduction in vascular event, while with the SGLT2 meta-analysis, it was 10% reduction. And not all trials were positive, but the benefit was, all the trials, it was in favor of GLP-1 agonist. Here you can see that the absolute risk reduction. Absolute risk reduction is the highest in the very high-risk patients. The highest was seen in the soloist heart failure study, where the absolute risk reduction was almost 10%. That means you need to treat only 10 patients to prevent one event. That was followed by the EMBERER reduced and the DAPA heart failure. Next was the DELIVER and EMBERER preserved. When it comes to the primary prevention, you can see that is almost near to the unity line. So we should be aggressive in treating our very high-risk patients. The patient cannot afford, at least the very high-risk patients, we should treat with SGLT2 inhibitors. Those with the heart failure, renal impairment, established cardiovascular disease. These 3 groups definitely benefit from SGLT2 inhibitor. So patient with heart failure, whether it is reduced ejection fraction, mid-range, mildly reduced, we call it now, preserved ejection fraction, all of them should be on an SGLT2 inhibitor. Despite that, the blood glucose is high, next agent should be a GLP-1 agonist. DPP4, cardiovascular safe ones, SITA or LINA. Insulin, the 2 agents I have specifically mentioned is the the insulin glargine and degludec. These are the 2 agents which have been shown to be cardiovascular safe. The red warning is on pioglitazone and, okay, just a couple of slides and we'll finish it. Yeah. And for heart failure, the SGLT2 inhibitors for primary prevention, it can be any of the 4. All have been shown to have primary prevention. For established heart failure, only 2 agents have been studied. That's the EMBA and DAPA. Sotagliflozin is not available. So for both for preserved and reduced ejection fraction, EMBA and DAPA can be given. And if you need further, GLP-1 agonist can be used. Further A1C reduction is required. DPP4 inhibitors which are safe for the SITA and LINA. Insulin, glargine and degludec. Then metformin can be used as a class 2 indication. The class 3 is for pioglitazone and saxagliptin. And always in patients with established cardiovascular disease, change them to agents which have shown cardiovascular protection. Suppose a patient is on a sulfonylurea or other agents which does not have cardiovascular protection. If the patient can afford, change them to agents with cardiovascular protection. This was the renal part. Everybody with a renal disease should be on a statin for vascular protection. Maybe atorvastatin was found to have a slight reduction in albuminuria compared to rosuvastatin. And they should be, the blood pressure should be well controlled. They should be on an ACE ARB in addition on finerenone. In addition, if needed, a GLP-1 agonist can be added. The flow study with semaglutide was prematurely terminated because of the overwhelming response in diabetic patients for renal protection. So there are studies on GLP-1 agonists coming up with cardiovascular and renal protection, including the SELECT and the flow study. This is to show that the benefit with SGLT2 inhibitor is the highest in the highest risk patients, both in diabetes and non-diabetes. Heart failure and CKD, they had the benefit, but without heart failure and CKD, the one top column, the benefit was less. Intensive LDL lowering, statin and ezetimibe combination. Statin-ezetimibe combination, the IMPROVE-IT study had a better benefit in diabetic patients compared to non-diabetic patients. Then despite that, the LDL is not controlled, go for PCSK9 inhibitor. Then finerenone in patients with diabetes and renal disease. And it is a patient-centered approach. And statin base should be everybody, but every diabetic patient should preferably be on a statin. Aspirin, the high-risk patients, established cardiovascular disease, all of them should be on aspirin. And the high risk and very high risk is a class 2B indication. You may give it, but downside is bleeding. The net clinical benefit is not much in the high risk and very high risk, but in the established cardiovascular disease is clearly proven to be beneficial. The primary prevention of heart failure, all the SGLT2, but for secondary DAPA and EMPA. Then the heart failure treatment, the usual first line drugs like ACE, ARB, ARNI, beta blockers and MRA. Intensive LDL lowering and SGLT2 in patients with kidney disease, finerenone in patients with kidney disease. Finerenone, the studies, the Fiderio and the two studies, the meta-analysis, there was a 14% reduction in cardiovascular events. Not only renal event, even the cardiovascular events were significantly lowered with finerenone. The albuminuria reduction. And these are the modification. They had included SGLT2 and GLP-1 in high risk when the risk score is more than 10%. This was not there in the 2019 guideline. 2019 only with established cardiovascular disease. Now they included 2B indication for high risk and very high risk patients. Again, that holds true for the GLP-1 also. The risk score is more than 10%, GLP and SGLT2. Insulin, glargine and degludec. Okay, thank you. Thank you.
Thank you, Dr. Korean, for your excellent presentation. Any question, please? So we'll go for next speaker, Dr. Ahmed Munir, consultant cardiologist, Mint Clinic Airport Road. Welcome, Dr. Ahmed.
Thank you very much. I don't have a PowerPoint presentation. I didn't forget it, as Dr. Mu'taz is claiming that I forget it. I didn't forget it. I want to make it an open discussion, okay? So I have seen that most of the presentations was like evidence and guidelines, so just let us be a little bit more, can you open the light, please? Right. So SGLT2 inhibitors in heart failure. Just will share each other experience. So if a patient come, you said that this patient having heart failure with reduced ejection fraction. Would you start all together, or shall you start with ARNI and you reach the maximum dose and you start to look for something else? Shall you start beta blockers and ARNI and mineralocorticoid, for example, and then wait for the SGLT2 inhibitors, or how we do it as an approach? It's just an open discussion, because this question, I have seen a lot of patients who comes either just for treatment or just come for preoperative assessment, and they have been followed up in so many hospitals. And thanks to Malafi, which is a link which can let us see all the visits, I have seen different approaches. So some physicians just concentrate on the ARNI and reach the maximum dose, and then they start to add on the SGLT2 inhibitors. Shall we start all together? Shall we start mix? So I will start with Dr. Joseph, because we didn't give him time for the question time.
See, as per the current guideline, we should try to start all the first-line drugs on board. Maybe on day one, we may not be able to start all the 4, but we should not wait for a long time to get to the maximum dose of one and then go to the next. As many, for that matter, the one drug which we can do, start with the full dose on day one, maybe an SGLT2 inhibitor. But we don't have to be too much worried about the BP, heart rate, and all the other parameters, including the renal function or potassium. Actually, hyperkalemia was less when the patients were treated with the SGLT2 inhibitor.
No,
So-
I'm talking, sorry, doctor.
Yeah,
I'm talking about the patients who are, they can tolerate. So how you approach them?
I try to put them on all the 4 pre-discharge.
Okay.
I try to discharge them with at least a small dose of all the 4.
Okay.
Then up-titrate in a reasonably fast time, not
So
taking
which
too
is the first one you up-titrate? The patient come to you after 1 week in the clinic. So of course, Arnie, you want to titrate after 30 days. But are you going to titrate the beta blocker first? Are you going to titrate the SGLT2 inhibitors first?
SGLT2 inhibitors, one advantage is that we can start with the full dose on day one.
Okay.
With the DAPA or EMBO, the advised dose is 10 milligram. We can start it day one itself.
Okay.
For ARNI, definitely, the blood pressure. The blood
Yes.
pressure holds true, then we can up-titrate in a faster, but if the blood pressure is on the lower side, suppose the systolic BP is near to 90, we may not be able to up-titrate
Yes.
that faster. And if the heart rate is high and the blood pressure is holding on, the beta blockers should be also up-titrated to the maximum recommended dose.
Okay. Thank you very much, Dr. Dr. Fadi.
Okay, so this is a patient, Ahmed, in acute setting, right? You're talking a patient in an acute setting, basically, or
No,
just
no, no.
an
A patient,
an outpatient clinic?
you diagnose him as HFrEF,
Okay,
and you're going to start him on the pillars for heart failure treatment.
okay.
So the question, shall you start small dose of each, or you keep in mind in one of the drugs and you reach the maximum dose first, and then you start to look for the other medications?
So if the patient is stable and he's coming on an outpatient basis, I never like that strategy to start the 4 pillars together.
Okay.
Because most of the patients will not really be tolerant when I start the 4 pillars of heart failure medications. And even according to the Heart Failure Society guidelines, in the literature, they mentioned that you should go start with 2 types of medications. Let's say, for example, ARNI, along with dapagliflozin, and then in a week, you can see again the patient to see how things are going, recheck the kidney function, potassium, and then you can go ahead and start with small doses of beta blocker, for example. If the kidney function is okay, you can introduce MRA. So I never started the 4 pillars
Okay.
altogether. Yeah.
Okay. Dr. Amira, what do you think?
For me, usually I'm starting the 4.
4 together.
Yeah, together at low dose, then up titration.
Okay.
Most probably I'm starting to up titrate the beta blockers first one.
Okay.
Yeah.
Okay. Dr. Amal.
Yes, I'm sorting the 4 together. For up titration, I prefer to reach the maximum dose for each one. If I can do at the same time, it is well and good. If not, for myself, I prefer to Entresto.
The sacubitril valsartan.
Yeah.
So you up titrate sacubitril valsartan till the maximum dose, and then you start to up titrate the others.
I usually I take up titrate all together.
So you start with the 4.
Yes, I start with the 4.
Okay.
Together, but first, only first, and then I can up titrate
Okay.
the other.
Okay. Yeah.
You can start
It is that's my way how I'm managing
Okay.
them.
Okay. Dr. Qais. You cannot come from Al Ain and you didn't say something. You have to say something.
Of course, the patients is not all of them will come in with the same features. Some will come with low heart rate. So usually I have a tendency to start all of them at the same time in a low dose and see them after 2 weeks like this. But as I said, if a patient come with a heart rate of 58, I will not jump to beta blocker rapidly. So it is different. It is different.
Normal patient, good blood pressure, and you have all the options.
Yeah, I will start
4.
with 4, yes.
Okay. Thank you very much, Dr. Chris. So, Dr. Ibrahim.
Actually, there is a consensus that we should start the 4 fundamental treatments together. We can start by small dose with up titration in the next visits. Myself follow this protocol.
Okay.
And I prefer it.
Okay. Thank you, Dr. Ibrahim. So, GP, you know, when they told me your name, I thought that you're like, you know, Formula driver or something, JP. So Dr. GP is a consultant cardiologist in Health Point, just our neighbor.
Thank you for the opportunity to put my view across. I think the key thing is that the patient is safe. And the key thing is knowing that they're going to come back to you soon enough so you can monitor renal function, you can monitor blood pressure. And my feeling is start all 4.
With the 4.
Especially as
Dr. Joseph
said, go straight in with a top dose of EMPA or DAPA.
Okay.
The issue being that, as you say, you know, there's seen in lots of different hospitals, they've got the Malafi data, but actually the challenge of prescribing and getting somebody back and getting them to be up titrated, I find, is the most anxiety-inducing part for me.
Yeah.
So start all 4 and try and up titrate each as you can, depending on which is the most important thing. If they're tachycardic, beta blocker goes first.
Okay. If you're gonna choose SGLT2 inhibitor, thank you very much. Do you have any preference?
I usually prescribe empagliflozin more than...
EMPA?
Yeah.
Okay. Is there any reason, or just because it was the beginning? We start with it.
No, in fact, dapagliflozin was as well old, but empagliflozin, like 10 milligrams, it's...
I mean, the EMPA-REG, when it comes, it paved the road for SGLT2 inhibitors, reduce hospitalization. Okay, so you prefer the EMPA with no reason?
If I have a patient on DAPA, I will not change it, definitely.
Okay. But if you're going to start, you're going to start EMPA.
EMPA 10.
Dr. Andron.
I think with the question about starting the 4 together of the pillar, I think it's very difficult to get the patients on the 4 at once. And that will depend on the blood pressure, mainly on the blood pressure and the renal function. So I think the general rules, especially if in patients, we would first like to stop the diuretics before we introduce all the other treatments. Otherwise, the renal function will deteriorate. And we've seen a lot of patients with normal renal function to start with, and then once you start them on, they're already on Lasix, diuretics, IV, and then you start them on the ARNI and TAPA or IMPA. And
which one?
Whichever. Doesn't matter.
So if you have a patient now, you're going to start them in SGLT2 inhibitors. Is there any preference, or both of them for the same for you?
I think both, probably both are the same. Maybe TAPA has better for renal protection. The renal doctors, they like it more. But I think for us, it's probably the same. But in terms of starting ARNI first, or and we have this patient, the one who came recently with acute myocardial infarction, severe LV dysfunction, ejection fraction like 25%, but his blood pressure was 80. Blood pressure was 80. He was actually asymptomatic with 80, but then we want to start them on ARNI. I don't think we can start them on ARNI, so we put him on TAPA, I think.
Yes.
10 milligram. And I think he's tolerating this well. Yeah. Renal function remained good. Yeah. So I think you have to choose your patient. You have to be. You cannot start all the patients.
So you don't have any preference for both of them?
For me, I don't have preference.
Okay. No. I will come to you. Tamer. Dr. Tamer, do you have any preference, DAPA or EMPA?
No, I think both are the same. So all trials, they both have the same effect, whether the DAPA and the EMPA.
Dr. Mu'taz. Okay. Dr. Joseph.
The heart failure studies, both the preserved ejection fraction, reduced ejection fraction, the combined endpoint of heart failure hospitalization and mortality was the same for both. It's very difficult to get the same endpoint, same percentage reduction, and incidentally turned out to be the same. 25 and 26.
Yeah.
So actually for the combined endpoint, there is nothing to choose between EMBA and DAPA in heart failure. I'm not talking about the...
No, I'm
EMBA.
talking about heart failure.
Heart failure. Heart
Okay.
failure.
I know that you treat diabetes, but I don't treat diabetes. So for heart failure?
In heart failure, as far as the trial results are concerned, there is nothing to choose between EMBA and DAPA.
Okay.
Both were equally effective, but due to some reason, the DAPA, the mortality was just reached statistical significance, while EMBA just fell short of statistical significance. But the combined endpoint was exactly the same.
Okay. Thank you very much. I am done with my presentation. That I did not forget it. I intended to make it in an interactive way. So now for the, Dr. Fadi wants to say something.
And I wanted to ask you.
For me?
For you and for all the colleagues.
Okay.
See, regarding the adverse events, and for Dr. Joseph as well, adverse events that we know, the notorious one, that which is, it's not very common, but we see it sometimes. I have like 5-6 patients who had the notorious adverse events of SGLT2 inhibitors, which is basically genital infections. So recently I had a Greek patient who had a severe balanitis, and we had to stop the dapagliflozin. So any studies or any literature is done, whether we can shift the patient to another form of SGLT2 inhibitors or he cannot benefit anymore, because the patient is a very good profile for the SGLT2 inhibitors, like heart failure, he has ASVD, diabetic, and he has stage 1 chronic kidney disease. So it's for everyone. I mean, in case you have any ideas.
So I have spoken with a lot of diabetologists because, you know, they prescribe these SGLT2 inhibitors much more than us. So they have, and it's written in the literature also, that with good genital hygiene, okay, and advices, it's not recurrent, okay? So they might get it in the first time, and it's not recurrent. But if it reached to a point that the patient has a recurrent UTI secondary to SGLT2 inhibitors, I don't think that we can use any if you use IMPA, you cannot use DAPA because it's a group effect, it's not a member effect. Could be the GLP-1, this question for you, could be the GLP-1 receptor agonist is a replacement, or shall we stop the SGLT2 inhibitors in general?
See, the urinary tract infection and the randomized control trials, not much different between placebo and SGLT2 inhibitors. It was almost, because diabetes is a condition where UTI is common. In the EMBARAC study also, between empagliflozin and placebo, it was almost the same. While genital mycotic infection, it was around 3 to 4% more with SGLT2 inhibitors, and most of them, as Dr. Munir already mentioned, it improves with the simple measures. But some of them get, 2 of my patients had circumcision done for, so now the urologists are getting more patients because we are putting them on SGLT2 inhibitors for the, but many of them, most of them improve with the simple measures, and recurrence with the genital hygiene, right advice, recurrence is not that common. But there are few patients where they refuse to restart them on because having balanoprostate is an unpleasant condition. So once they had it, but I think with the circumcised people, the genital mycotic infection is still less. So we see less of these things because the practice of circumcision here.
So we end with circumcision. Okay.
2 of my patients had that.
So you are a cardiologist and you advise for circumcision for anyway.